Okay. Hey ladies, welcome to another episode of the Core for Momentum podcast. This is your host, Dr. Amy. Today I have the pleasure of interviewing Dr. Terri Elder. She and I will be talking about pelvic organ prolapse, which surprisingly we have not covered yet in our podcast. So I'm really excited and pumped to hear about Dr. Terri's experience with this and treating pelvic organ prolapse. So a little background, I'll do a little introduction for Dr. Terri. She is a physical therapist who specializes in pelvic health, oncology, and orthopedics. And she is the owner of Thrive Pelvic Health in Brevard, North Carolina. So same state as me. Thank you for hopping on our podcast.
Absolutely. Thanks for having me.
Is there anything else you would like to add about your practice or anything that you want our listeners to know about you before we dive into pelvic organ prolapse?
Well, I also teach at Georgia State University. I love working with physical therapy students, and I also teach fitness classes, Pilates, yoga bar, and do also CrossFit myself and running and lots of other fun activities. So that's kind of my passion, and yeah, just really happy to be here and speak about this topic that is really I'm so passionate about because it has really motivated me to kind of be the provider that I needed at the time when I was diagnosed with one. So yeah.
Yeah, I feel like it makes a huge difference when you're sympathetic, like you went through it yourself, and then you can provide a little bit more like insight to clients and patients who are going through the same thing.
Yeah, and I don't think you necessarily have to have experienced everything that you're treating, but I think it definitely gives some valuable insight for me, for sure, as to what it's like to actually go through it a couple times, actually.
So, and I was just curious, I wanted to ask you these two questions just about like why you wanted to be a physical therapist and like why specifically pelvic health, just to kind of get a little background on what drew you to it.
Sure. Well, my journey to physical therapy, I started actually as a massage therapist. And then I added on yoga and Pilates teacher certifications. So I loved, working with people in movement, but I really just wanted to do more. And so after going through a divorce, I just decided, okay, well, what am I going to do for me now? And I decided to go back to school, and I didn't graduate with the doctorate in physical therapy until I was, I think 30. I was in my mid to late 30s. So I was like the old kid, in in our class. But I had an interest in pelvic health. It's funny, it wasn't necessarily clear to me right when I graduated from PT school that was what I wanted to go into. But when I found it, I was like, oh, this makes so much sense, because like I was the friend growing up who like taught all her other friends how to use tampons. And I was the friend who, tried to even show her like guy friends or help her guy friends understand like where the clitoris is, because like they need to know, right? So my interest in teaching about pelvic health started very young. And when I came to the specialty, I was like, oh my gosh, this is it. This is my jam. So, you can find me over in the corner whispering about pee, poop, and sex with people at, cocktail parties when we start being able to have them again. And so I'm so just happy that's what I get to do for my job, is help people with their most intimate concerns that often they're not even talking to their normal providers about. So, yeah.
Yeah, I definitely find that too. It's different when they have a whole hour with you and they can really get a little bit more comfortable and like personal about what they're really concerned about when it comes to like pelvic floor.
Yes, absolutely.
Yeah. So we'll dive right into POP, or pelvic organ prolapse.
Do it.
Okay, so Terri, if you could tell us, I asked a few questions on social media, and a few people responded. So if we could start with like, what is pelvic organ prolapse? It sounds really scary. So if you could go into that first.
Yeah, it does sound scary. And I mean, I even remember growing up, my mom telling me, like, the first time I ever heard about it, my mom was like telling me about some friend. Oh, her organs are falling out. She had to have this surgery. It was just terrible. And I remember that really like made an impact on me. And so when I was diagnosed following the birth of my son, I was like, oh my gosh, this is going to be me. I'm going to have this mesh put in and, all of this stuff. And, just to share a little bit more about, I'd love to share a little bit more about that story, if that's okay.
Yeah,
So yeah, I went for a pelvic health evaluation. My son was 6 or 7 weeks postpartum, something. I had tried to have sex. It was terribly painful. And at that point, I already had taken one pelvic health course and started doing some observation. So I was new in the specialty. So I went to see my colleague, and she evaluated me. I didn't have any symptoms of POP, which I will get into what that is, but I didn't have any feelings of, organ descent, heaviness, pressure, feelings of a bulge, none of that. But she told me that I had a grade 1 to 2 prolapse, gave me a handout of all the things I'm never supposed to do again, which on the list was having 2 feet leave the ground during a run or a jump, squatting with my hips below my knees. Like when I've been into low cabinets, I'm supposed to go down to one knee now, nothing high impact anymore. I was given this handout, and that was pretty much it. She treated the dyspareunia, or the painful sex, and some other things. I had a small diastasis as well, but not much more was done with the prolapse. And I just kind of felt like it was a bit of a death sentence, to be honest, because I love running, jumping, doing all the things. And that's why I mentioned, that what my activities are. And so I, wanted to do a lot more research. So I took the Pop-Up Pro course, which is a very intense, very, very in-depth course on prolapse for movement and professionals, as well as pelvic rehab professionals. And that completely opened my eyes to everything that I'm going to share with you all today. So, and then recently I found a prolapse in a different area. And it was really interesting for me to kind of go through again that the fear and the coming to terms with, body changes and all the questioning. Did I do this to myself? What does this mean for my future? Da, 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 da. Even with all the information and the knowledge that I have, it is still perfectly natural to go through all of those feelings. So to go back to what prolapse actually is, in my own words, prolapse is pelvic organ descent, which basically bulges, kind of presses into the vaginal walls. There are different grades, so meaning it can be just a tiny bulge that's very internal that you may not even know that you have, to something that feels closer, descending closer to the opening of the vagina. And then there can also be pelvic organs that bulge into the vagina that actually bulge outward of the vagina. So there are different grades. As far as the actual clinical definition, this is from the International Continence Society and the International Urogynecological Association. They came out with a joint report, and their definition of it is, quote, a departure from normal sensation, structure, or function experienced by the woman in reference to the position of her pelvic organs. So this is quite vague. I think so. It basically could even, by this definition, be the sensation of the experience of the position of the pelvic organs. It could be something functional, it could be structural, and it can be, a variety of these things. So again, this is a kind of a vague definition, but typically how we diagnose it in clinic, or how it's diagnosed by urogynecologists, would be, looking inside the vaginal opening, having the person bear down and seeing if there's more than normal organ movement or organ descent that presses vaginally. There are a lot of different names, and it depends on kind of which organs seem to be moving more. Do you want me to get into all the different names?
Yeah.
Just
Yeah.
mention them?
Yeah,
Okay.
them.
Sure. So rectocele is when the posterior wall, or the wall that kind of sits between the vagina and the rectum, kind of presses into the vagina. A cystocele is when the bladder drops down. A vaginal vault prolapse is when the top of the uterus, depending on, or the top of the vagina, depending on, the nomenclature may change based on whether or not the uterus is present, but that kind of presses down. And then there's also one called an enterocele, which is when the intestines may kind of press in. So rectal prolapse is something different, just to clarify. So that is the actual rectum kind of prolapsing outside of itself. But a rectocele is the rectal wall that just kind of pushes into the vagina. So that is kind of a common misunderstanding, but it doesn't necessarily change too much as far as how we address it and how we approach it and treat it. But it may change symptoms and things like that. So so that is the basic definition in my story in a nutshell.
Yeah, no, it actually, I didn't realize that the part that really sticks out to me was the part with like the sensation and experience and the like official definition. I didn't realize that, and that's very interesting to me, actually.
Yeah, there's a different, I can't remember exactly which one, but there's a different international association that only defines it as the having it be symptomatic, which is really interesting. So even if you have an organ descent, if it's asymptomatic, they don't necessarily consider that to be, a diagnosis of prolapse. So
yeah, and that's also really, and I think you're probably about to get into this, but it's interesting because some patients will have a significant prolapse and then they don't even feel it. It doesn't bother them at all. And then other people will have a tiny one and it'll bother them so much.
Absolutely. And that's absolutely supported by the literature, is that symptoms and presentation do not align. People can have very symptomatic prolapse and there's not much organ descent happening. And some people are not bothered at all by their organs just occasionally just kind of completely coming out. And put them back in and move along with your day, Yeah. So it really does depend on the individual. Yeah.
Mm-hmm. Yeah, that's always been really interesting to me. Another question we had was, how common is it?
Yes.
Yeah.
This is a really interesting question to me. So it really does vary widely, the prevalence, because the definition varies. So prevalence is going to vary based on what criteria you're using to define this condition. However, one big study in 2005 found that 22% of the population, not 22% of women, but 22% of the population had a grade 2 or more. So that's super high.
Yeah.
There's one other study that shows and this is a huge wide range, but between 30 and 90% of individuals have it. One other study that I saw showed that more than 50% of people who have birthed a child in any way have at least grade 1 organ descent. So why this is important is, yes, it is really, it has a very high prevalence. And what it makes me wonder is there a certain amount of organ descent over time as we age that should be considered normal and not pathologized?
Yeah.
Like perhaps this is something that organs shift and move as we age, and we experience differences as we age. And yes, our connective tissue loses some of its strength and oomph. And this happens all over our bodies, to our skin, to our discs, to our whatever, so wouldn't it stand to reason that also sometimes this, our pelvic organs would descend as well. So when it becomes a problem, that's what I find interesting, and how to help people who do find it problematic.
Yeah, that almost reminds me of like the classic disc degeneration, like
Mhm.
MRI done, and it says that, and they're very worried. But then it's like, well, that's just like a wrinkle, that's a normal
Yeah.
part of like
Yeah.
aging.
Wrinkles in your joints or
Yep.
wrinkles in your disc. Yeah, absolutely. I've been meaning to post about that lately, actually.
Yeah, I love that. I love that. I'm always like, that's not a big deal. It's okay.
Yeah. Yeah. Your
Um,
pain's a big deal though. Let's talk about that.
yeah, yeah.
Yes.
Um, and another question that we had that I think is really important to cover also, it's kind of a two-part question, but it's like, who is at risk for pelvic organ prolapse, which we talked a little bit about, but also like, can that happen in, I think we associate it with pregnancy and postpartum a lot of
Mhm.
times, or like aging, but can it also happen in someone who's not pregnant or never like has been pregnant?
Sure. It definitely can happen regardless of your whether or not you've had a child. However, the biggest risk factor for POP is having a vaginal delivery.
Mm-hmm.
So that is the the highest risk factor. Now, I hate to say that I don't want to scare anyone, but that is, let's just be real with that's what the literature says. Now, there are also other things that really increase your risk of developing prolapse, and that is the use of forceps during a delivery. So it's not necessarily shown with a vacuum assisted or with a episiotomy or with other methods, but there's a very strong association between use of forceps and levator ani, a avulsion injury, which is when the pelvic floor muscles have an injury, and then the development of prolapse. So that's probably the number one kind of modifiable factor. There are other risk factors that are non-modifiable, such as increasing age. So non-modifiable meaning you can't do anything about it, right? Increasing age, family history and genetics definitely play a role. Connective tissue disorders. So for people who have maybe not quite as much collagen, and you may not know it, but if you have a diagnosed connective tissue disorder, such as like Ehlers-Danlos syndrome, things like that, that may increase your risk as well. And then having, and these are potentially modifiable. So having asthma or chronic cough. So I do have had patients who come in and they, have prolapse or they have, other pelvic health symptoms. And I noticed they're coughing throughout. And one in particular, a woman comes to mind recently, and she's like, yeah, I have the steroid inhaler. I don't like using it. I don't like using medications. I was like, well, if you can reduce the cough, that's reducing the impact chronically throughout the day on your pelvic floor. And then also having chronic constipation is a modifiable risk factor. And then the other big one is heavy occupational work. So literature does support that this can increase the risk of prolapse, and it's defined, heavy occupational work is defined as greater than 2 of the following: either standing 50% of the time, heavy lifting more than 20 times per week. Heavy lifting is more than 50 pounds. And then self-reported physical heavy work. So if someone just says, no, I do physically heavy work, that kind of counts as 1. So fitting at 2 of those of the following increases the risk. And then studies are conflicting as to whether or not BMI plays a role. So some studies show that higher BMI is a risk factor or a body mass index. And some studies show that that is not the case. So evidence is conflicting there. So that's a very complex and loaded conversation. So I would certainly avoid, if clinicians are out there telling your patients to lose weight to manage prolapse, that is absolutely not evidence-based. However, people may find that their symptoms reduce when they do lose weight, but it's, hard to say, well, is that because you've been more active and you've been strengthening, or your mental health is better because like there's a lot of factors. So it's hard to say, A
Yeah.
to B with that.
Yeah, no, that's a good point. Have you ever worked with, I know you said you do CrossFit. Have you ever worked with like a weightlifter or CrossFit athlete that's been dealing with prolapse and, that's like their sport. And so they're going to be heavy loading themselves like all the time.
Yes, yes, absolutely. So, and runners and other things that were on that list of things that I'm not supposed to do, which
Yeah.
by the way, I definitely want to just say, very clearly that there is, I just did cover the risk factors, but there is no single identifiable or preventable cause of prolapse. And the benefits of exercise greatly outweigh the risks, greatly. And so whether or, there's really, also no way to categorize and say, do this, don't do that. This exercise is safe, this is not. And the reason why we can't say that is because tons and tons and tons of studies of where they take intra-abdominal pressure measurements with people in different various positions show that the amount of pressure that's generated is completely different for different people with different activities. So you really cannot say that certain activities are safe and certain ones are unsafe. It's really about how things are done. Same as right with everything with therapy and fitness, the how is more important than the what. So, I certainly look at what people want to do, look at what their strategies are with, particularly with pressure management, with how they're managing with pressure. Are they bearing down during exercise? Are they kind of what's happening with the rib cage, what's happening with the abdomen, how the pelvic floor is functioning to help support those pelvic organs, all of those things. And then, using the principles of training, progressive overload. I could get really nerdy with it, but basically allowing the body to gradually adapt, optimizing the strategies that you're using. And you can do whatever you want with your body. That is absolutely what I love to help people with, because I hate those blanket rules, and they're really not evidence-based. And it's hard to give people nuanced things. We want to be clear with people. We want to say, do this, don't do that. Here's a handout. That's the easy way to go. And not everyone, really understands the nuances of how to help coach someone who is dealing with prolapse or or other, pelvic health issues. But absolutely, you can do heavy lifting, explosive movement, running with prolapse, 100%. Yep.
Yeah, I think that's a huge place of like fear for a lot of people. A few weeks ago, I had evaluated someone who was, and I think this is my first time seeing it, so it was very, I think I'll remember this forever. But this particular person felt like her life was over. And she was like, well, I can't walk. I can't walk. I can't go on my beach walk. I can't ride my bike. I can't do this. I can't do that. I can't lift. I can't move anything. And she was like, what am I supposed to do? Like, I can't do anything. And I think that was the first time I had seen it impact someone like that. Actually, I've seen different
And that was because of her prolapse?
yeah, because of her prolapse. And I had seen different variants of that, but like not that extreme. And so when I saw that, it was very, I guess, shocking to me, how much that had impacted her. And she was like limiting everything. Like she was an older woman, super active, and then completely just stopped like everything.
Was it because her symptoms would crop up during these activities, or because she was told not to do these things or afraid to do these things based on what she found on Dr. Google?
I think it was a combination because she had been through a couple operations already, and she was very emotional about that too, and didn't have a lot of like guidance from her like referring provider. And I think her provider didn't really explain what pelvic PT was going to help her with, because she came in and was like, what is this going to do? So
yeah. Sorry, I didn't mean to turn the tables on you there, but I'm
oh,
of course.
no, that's fine.
one of my mentors who is a very big he's an Australian physio, and he's in women's health, one of the few and proud men in women's health, and his pretty well-known quote is, restricting activity in the hopes of saving a vagina is not promoting holistic women's health.
Wow.
Antonino is the name of the guy. So, and that really is true. I mean, we are more than our vaginas. We are more than our vulvas, and that's why I say it's your body, and it's up to you to do what you want with it. And at the same time, I very much want to help people manage their symptoms and find ways to do things that don't, bring on the perseveration and the fear and the worry of, am I going to make this worse? Because that is the fear for a lot of people, right? They want to, if they know they have a prolapse, they don't want it to get worse. They want to avoid surgery, things like that. Or if they've had surgery, they want to avoid having another surgery, because the failure rates are really high, right? About 30%.
Yeah.
30% failure rate. So, that is definitely a valid fear. I completely understand that. So as far as, showing correlations between doing certain things, doing certain activities, having a second baby, things like that, there really is no strong association between these things and having worsening POP. So, and we have a good bit of literature at this point. We can't point to any one thing for reasons why prolapse would worsen, either symptomatically or structurally.
Mm-hmm. I feel like that can definitely ease the fear.
Yeah.
One of the other questions that we had was how to prevent a prolapse or how to heal one after giving birth.
Let's get into it.
Yeah.
So let's talk about prevention first. So like I said, since you can't point to a single identifiable or preventable cause, really it is understanding your risk factors and then minimizing the ones you can modify as much as possible. So we can't change our age, we can't change our genetics, right? Mm-hmm. And like I said, we may or may not be able to, an adjustment in BMI may or may not have any impact. So managing constipation, managing asthma, managing chronic cough, other lung conditions, things like that. Maybe if you do consider yourself one of those who does the heavy occupational work and you have other risk factors, and it's something that you are open to changing, wanting to change, possibly changing that. But again, that's completely up to you. If you love your work and that's what you do, and that's, that I'm not telling you change your work. So I don't want anyone to hear that. And then, as far as those managing POP or trying to prevent POP who are expecting, then knowing that the use of forceps is one of the risk factors, and then, having that be maybe a part of your birth preferences when you do, and discussing it with your birth team, that you do want to avoid, use of forceps. And you can come up with, avoiding use of forceps and unless, baby's life is at stake or something like that, or mother's life is at stake or whatever, coming up with some things and different things happen in the moment, but it can be very helpful to have providers understand. So then as far as second delivery, like I said, there's a good bit of studies that show that there's not necessarily a correlation between subsequent vaginal deliveries and increasing severity. So know that. And there's not a lot of evidence to my knowledge about birthing strategies. However, I do think that the way that we labor and the way that we deliver, that you can have some strategies to where you are reducing the impact on the pelvic floor. Mm-hmm. So some of those are not doing what's called the purple pushing, right? Which is how it's coached. It's how we see it in the movies. It's how we're taught by, current understanding of how women are supposed to birth, to bear down and push as hard as you can and get that baby out as quick as you can. Well, guess what? It may not give your pelvic floor muscles time to lengthen and stretch the way that they need to. Pushing down like that, it may not be needed. Now, if you've been laboring for a very long time and they're trying to get that baby out, you may need to do some bearing down, but often, the uterus is doing its work to contract, to push that baby down. And there's lots of different things we can do with positioning to facilitate, the movement of getting the baby out. So I would definitely work with a pelvic PT. Having a doula definitely shows that there are less interventions. Having other people supporting you and knowing what your birth preferences are can really, really help. And then understanding that, there's something called, so the other part of, how do we get the baby out without purple pushing? There's open glottis pushing, which is when you actually would be able to blow oxygen out of your lungs as you kind of bear down. Now, some people don't actually need to even give that extra push, because again, the uterus really is doing the work there. And there are some good resources we can put in the show notes for those who are interested. Gentle Birth, they've got a lot of great videos and information about those types of strategies. And then Evidence-Based Birth is another one that has great information. And again, is evidence-based for how to kind of optimize, mothers and babies, birthing person's health around delivery. So that was a lot. I hope that wasn't too much info.
I just wrote down those 2 resources and I'll put them in the show notes because I think that's so important. It's so hard because I haven't been through it myself, but I've heard from one of my old colleagues that, she was a pelvic PT, and she said that when she was there in the moment, they were yelling at her to like hold your breath, push and everything. And she was like, and I did it. She was like, I couldn't help myself. And she did it. And so I think that it's good to provide those resources on alternative strategies, opposite to what someone might be yelling at you to do.
Yeah. And, it's interesting. And then people may not even be yelling at you, but you kind of are somewhere aware in the back of your mind that that's the expectation, particularly with a hospital birth, which I elected to have a hospital birth because I was already in my 40s when I delivered my first baby. But so, and there can be other really subtle things. But what I experienced was my OB came in. It was someone who I hadn't met. I happened to hit the one day a month where no one from my OB practice was available, and this random doctor was there. She came in. She didn't even look me in the eye or introduce herself. She just looked at my vulva, said, push. And then she looked at the L&D nurse and she was like, it's going to be a while. And she turned around and left. I was like, oh, I'll show her. And I did. I showed her. That baby out really quickly because I'm competitive and don't tell me I can't do something, So, it may be a lot more subtle than people yelling at you to push. But anyway, yeah. And there are, just to say that there are definitely people who elect to have cesarean section, either after they don't want to try for a VBAC or a vaginal birth after C-section. They just want to go ahead and schedule that their second child or subsequent children for another C-section, or they elect after having a vaginal delivery to opt for a C-section. And that is a completely personal decision, and there are so many different options to weigh. So, I definitely, don't offer judgment one way or the other. And when people, do that. And I have a good friend who is going through that right now. She wants to have another, I'm just gonna do another C-section. I said, go for it, do it, like it's not, there's no shame. I don't know why, there seems to be in the birth field shame around, having a C-section, or as I have now started calling it, a belly birth, because they can be beautiful and supportive, and it may be the best decision for mother and baby and parents, whoever. So just wanted to throw that out there. Absolutely nothing to be ashamed about making that decision of what is best for you.
I love that, a belly birth.
Mm-hmm.
So, and this is actually one of my questions. It's not really a question, and we've kind of already talked about it a little bit, but I wanted to get like a little bit more into like the emotional and like psychosocial impact of POP, just because of, I gave you the example of recently I encountered that. So how did you deal with the emotional side of it, and how do you like coach your clients through that, or refer, or anything?
Right. Yeah. Very good question. And actually, in asking that, I realized that I didn't fully answer the last question that you asked. So before I move on to that, I think there was the one about, how do you heal a prolapse?
Yes.
That I forgot to address. So there is varying schools of thought on whether or not prolapse can reduce by 1 grade. Some say that, if you have a grade 2, you can reduce it to a grade 1, things like that. But, that really is not the goal of treatment for me, because I feel like that's not necessarily, an attainable goal. That's not what I don't write in my notes, like grade of prolapse will reduce by blah, 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 because that's a structural change. So I really focus on function, people being able to do whatever they want, symptoms, symptom bother and symptom reduction. And we'll get into that more in just a moment with the psychosocial aspects of care. And, that's really what I want. So if it doesn't bother you and you can do whatever you want, can we call that healed?
Yeah. That's how
Yeah.
I call it healed. I think that is a hard thing though, because people do come in and they're like, well, I want it to go away,
Right. Yeah.
And so that's a hard conversation, but
it is. That's hard. And I mean, there are, I want my wrinkles to go away too, but I can put some cream on them and they maybe look a little bit better, and they, we drink our water and we get our sleep, and we find ways to manage these body changes as we age. But some of it really is kind of coming to terms with, again, the changes in our bodies. And this is a beautiful segue into answer that last question that you asked is, how do we coach people? How do we help them? And, for one, and to just say for you, for other clinicians that are out there, it's not our job to heal people. It's not our job to fix people. And we take that on ourselves, and people maybe expect it, but we do, kind of need to say that I do consider myself more of a facilitator, more of in that coaching role, an educator. Even that is a little bit sticky, but really helping people find their own answers, find their own way. And it's up to people to do the hard work of, making the changes that they need and want to make, that really produce the change for them in their lives. So that being said, I really do understand that stages of fear and grief and acceptance that come around some of these, an understanding of a new body change. So just to share like a little bit more of that story. So I was doing my monthly, this is the most recent kind of, this is not the first prolapse that I was diagnosed with, but most recently I was doing my hand mirror check, which I recommend we do about every month or so, just to like notice and see if there's any changes, things like that. We do our breast self-exam. It's good to do a vulvar self-check, or for the boys, check those things out too. So see if there's any changes. And I was like, what the heck? This looks like rectocele. Like I'm seeing some posterior wall movement that I didn't see before. And it can be It can be, as a pelvic health therapist, we can be a little bit more attuned to these changes. We see things all the time, and there are those of us who are known to be hypervigilant, and there are some individuals who do, are hypervigilant, and I'll talk more about that in just a moment. So I was like, okay, so I did some bearing down. I saw some things I didn't love, and I had all the feelings, what have I done? Did I do this to myself? Again, we don't know that we can do these things to ourselves. And I went out for a run. That's what I did, because I went out for a fuck it run. Sorry to just say it, but I was like, ah! So I needed to go pound on the pavement, because I am not going to let something like this, slow me down. And perhaps it was just what I needed to kind of get my head right. Perhaps it was an FU to whatever body changes I was experiencing. Maybe it wasn't the best idea, but it was what I did at the time. So, and then it was, reaching out to other practitioners. I went and had it assessed with by a urogynecologist to see if I could be fit for a pessary, which I would love to talk about pessaries more. Unfortunately, I'm not a candidate for one, because it's really kind of too caudal. It's like right there by the opening, so a pessary wouldn't really do anything for me. But so I found out that I actually have a little muscle injury that I didn't know about. And so I had to kind of wrap my head around that. And now, I've come to a place of acceptance and understanding that, I am strong. I can do the things that I want, and just the same with everything, we have to be progressive about what we do to allow the body time to adapt. And so that really is so there's a new acronym that I heard that I absolutely love for SCAR, the word SCAR: strong, capable, adaptable, and resilient. When we have a SCAR, when we have an injury or some other body change, it gives us the opportunity to be even stronger than we were before. SCARs are known to be, again, like I said, strong, capable, they can move, they can become more resilient, they can still adapt to change. Same goes for anything in the body across the entire lifespan. The body will adapt to changes that we, stresses that we put it under. So we do, though, have to actually, stress to progress, meaning we have to find ways to lean into the hard things so that we do stimulate that change. So, depending on what someone's goals are, whether or not it's feeling more comfortable about something or something physical that they want to do, talking about it can help. But then again, leaning into the hard stuff. So I do, to roundabout come back to your question, I do sometimes assign people or offer people readings that they can do. Sometimes I do recommend, speaking to a counselor, because I think it's so important for people to discuss these body changes. And, I will share the story of one of my favorite clients who I've worked with, she has a very structurally mild prolapse. Again, it could even really be considered within the realm of what is normal for body change, and not, so it would be defined as like grade 1 to 2, kind of somewhere in there, definitely above the level of the opening of the vagina. But she has a huge symptom bother, or she's gotten a lot better, but she was very hypervigilant, checked every single day with a hand mirror, with her own finger, checked, wanted to know, was taking videos, was wanting to assess change, had this goal of reducing or eliminating her prolapse. And, so I did coach her to not check as often, because some of this hypervigilance of, constantly checking, I think does actually change the brain to where you are more, again, that hypervigilance causes more awareness of the thing. So you're not really, you may not feel your arm, but when you start thinking about your arm all day long, well, then that arm becomes like bigger in your brain. Not to go into too much weird like neuroanatomy, neuroscience stuff, but it really does. So the more you attend to something, the more you think about something and focus on it, the brain actually changes in response to that. So finding ways to distract, finding ways to focus on strengths, finding ways to focus on what it is you're doing, has really, really helped. And so she has come light years to where she's doing, she's gotten back into impact exercise, running, lifting really heavy weight. She's always athletic. So she's doing like really, really high level stuff, and, really doesn't seem to have symptom bother, and she's, doing great. So is absolutely, something that does take time. Your body takes time to adapt, your mind takes time to adapt, but absolutely there is hope for people experiencing these changes and these symptoms.
Yeah, that's a great story of like success and hope, I think, that people need to hear too. You had mentioned pessaries briefly. So there are other, obviously pelvic PT is a huge part of management, but then there are also like medical interventions too.
Absolutely. So this is a great thing also to mention the management strategies. So pelvic health PT for sure, and a lot of what we do is movement strategies, breathing strategies, education on what was happening with the pelvic floor, because the pelvic floor can really get a lot stronger to help compensate for if there is, ligaments that maybe aren't quite as strong as they used to be, things like that. The pelvic floor can kind of help float the boat, as it were, and support. And then another consideration is tissue health and hormone status. So definitely as we age, vulvar and vaginal tissue through the hormone changes loses collagen and loses other kind of things that help with structural support. So moving into perimenopause and menopause, considering topical hormones, meaning either hormone creams placed externally or internally for everyone, not just for those managing POP. That is definitely like something I want to shout from the rooftops. So talk to your doctors about it. It is safe even for people who have hormone sensitive cancers, because things don't get absorbed systemically. So this is also a big consideration for postpartum people, because if you're lactating, your hormone status is that of someone perimenopausal or menopausal, basically. So consider tissue and hormone health. And then pessaries are a huge way that you can support your pelvic organs as well. And essentially they are a medical grade silicone device that there are a lot of different shapes and sizes, because we are all different shapes and sizes. People have, and depending on where your organ descent is kind of occurring, different pessaries may work. So some are just shaped like a ring, some are shaped more like a cube, and they're used a little bit differently, again, depending on what's going on and depending on preference and the ability of the person to kind of put in and remove it. So some are put in and they just stay in. Some, the person may only choose to use it, for example, during like high impact activity, just to feel extra supported. Some of them can be left in place during intercourse, things like that. So there's a lot of different things. And if you wanted to be evaluated for one of those in the United States, you go to a urogynecologist. In Canada and Europe and many other countries, pelvic physios, pelvic PTs can fit pessaries. We don't yet here have the training to do that. However, I do think it is well within our scope, and the APTA Pelvic Health Academy, the Academy of Pelvic Health has a task force working on defining what those guidelines would be and working on promotion of that, being a more common practice in the United States. So for now, see a Urogyne. Hopefully in the next few years, we'll have some pelvic PTs working directly with pessaries as well.
Wow, I had no idea.
Yeah.
That's really cool.
Very cool.
Okay, so we talked about pelvic PT, pessaries, and we touched a little bit on surgery and like the success rate with that. Was there anything else you wanted to add to any of the management techniques?
I just definitely want to say that also that sex might feel different with a pelvic organ descent. And it's really not weird if you are not feeling sexy following a diagnosis, because I get that. Like when your sexy parts are like oh definitely it can change your genital body image. It can change the way things feel, and depending on where you are in going through the process of acceptance and the process of rehab, either physical or mental, it may be good to give yourself some time and just say, like, that's okay that things are feeling different right now, and that's okay that I'm maybe not feeling it right now. But again, then going back to all the modifiable things that you can work on, and definitely addressing the mental health piece can be really helpful. And then I think that's really it. I think I got most of my big stuff out.
Yeah,
Yeah.
good. And then just to kind of wrap it all into like a package, what is like one major takeaway you'd want listeners who do have POP and are stressed about it to know, like leaving this episode?
You didn't do anything wrong. And the best thing that you can do to feel better is to give yourself space and time to heal. And again, gradually lean into the things that challenge you so that you can get stronger and build the adaptation, and know that you're resilient, and that things may look different than before, but you can 100% get stronger than you ever were. And there is nothing that's off the table for you. You can do whatever you want. Yeah.
Thank you. That was beautifully said.
Thanks.
Okay. Well, I always ask this at the end. How can our listeners connect with you, Terri?
Yeah, I would love for anyone to reach out that has questions about it, or that wants more resources or wants more support. I'm most active probably on Instagram, and you can find me at Terri Terri.elder.dpt. That's my Instagram handle, and I do post a lot of pelvic health stuff, as well as general rehab and fitness, and then random. It's my personal account too, so family, food, whatever whatever's on my mind. I try to approach it from humor anyway, so hopefully it's educational, funny, and then my website is thrive-pt.com. But that is linked into my Instagram too. So if you just go to my Instagram page, you can look at my handle there. And I do, consultations, pre and postnatal coaching, as well as virtual rehab. So my links are there on both the Instagram and the website. And I'm trying to think if there's anything else. Yeah, that's the best way.
Okay, perfect. So I will drop Terri's Instagram handle and website in the show notes also, along with the birth videos.
Oh, great.
Yes. Well,
there's one other resource that I want to share, actually, and that is the Pop Uplift Instagram page at Pop Uplift. And that is believe it or not, Instagram was the thing. An Instagram account that I found was the thing that started to change my thinking as a rehab professional, and helped me find the resources and dive into this really deep understanding of something that was really personal and affected me greatly. So there is still the power of social media out there, and that is a wonderful resource for both practitioners and people who either have POP or have fears about POP. Really a great resource, and they have I think free downloadable little brochure handout things as well. So check that out.
Very awesome. I'll add that too. Thank you. And I'll look at it myself.
Absolutely.
Well, thank you so much for hopping on this episode. It was fun to talk about, and I learned a few new things about prolapse too.
Yay. Thanks so much for having me.